Hi, everyone. Welcome back to Both Sides of the Stethoscope. This is episode 7. I am Dr. Colby Salerno, here with my co-host, Dr. Alin Gregosian.
Hi, everyone.
And today we're excited. We're going to be interviewing another solid organ transplant recipient, but this one is going to be interesting because he practices in infectious disease. We're here today with Dr. Steve Pergam. Hey, Steve, welcome on.
Hey, guys. Thanks for having me. Really appreciate it.
Yeah, we're happy to have you. I don't know if you've listened at all to the podcast, but I've actually mentioned a couple times my nervousness with working in infectious disease as an immunocompromised person. And here you are doing that exact thing. So I'm very interested to pick your brain today.
It's incredible. Steve,
Yeah, sure.
you're one of like our role models in transplant medicine in many ways.
Well, thank you both. I obviously have listened to a number of your episodes, and it's really a highlight for me to be here. Such an interesting place to be for all of us, I think, in positions where we're both immunocompromised and also taking care of patients. So I think an important thing for everybody to be aware of.
Right.
Yeah. So before we get into, I think the hot topic of the last couple of years in terms of infectious disease, I'm interested to hear,
Sure.
What initially made you want to become a doctor?
Yeah, I don't know. I mean, I had, both my parents are physicians, and I think that was sort of a natural fit that, eventually I might do something like that. But I definitely explored a lot of other things. I was an art major in college and taught art for a year after I finished. So I definitely, it wasn't necessarily something that I felt like I had to do, but it felt like the right fit for a career. I think I'd always sort of known a little bit about from talking about medicine at the dinner table as a kid and getting kind of excited about science. I really liked the science and the other aspects of the training to get to medical school. And I don't know, it just felt like a natural fit. I don't know, it's kind of hard to go back and sort of imagine like why anyone decides to do what they do, but I think that was probably the biggest things for me.
I know you're a kidney transplant recipient. Did you get your kidney when you were younger or more recently? And was it due to chronic kidney disease?
So I, when I was in high school, I developed a post-viral kidney disease. So don't really know the etiology, never will probably know what the etiology was. But after getting a cold, about 2 to 3 weeks later, started to have some leg swelling and was found to be in an acute renal failure. And was able to get on treatment right away with some immunosuppressive therapy initially. And that sort of kept me going for about 15, 16, 17 years. And I got transplanted actually when I was, I'd finished med school, had been a full-time attending for a couple of years afterwards. And that was prior to my training in infectious disease. And it was kind of a slow progressive process where, I got to the point where it just got harder and harder to manage the fatigue and other things that we eventually just decided that's what I should do. I got a living related transplant from my mother.
That's incredible. That's like our previous kidney transplant recipient that we had on here, Dr. Ken Sutha, who received it from his father. So again, I always have to give shout outs to a living donor. That's amazing. For your mom to have been a living donor, such a hero in my eyes. So you said that you were
to everyone's eyes, I would say.
Yeah, exactly. And to all living donors out there, and even all deceased donors, organ donors in general, are all heroes, as we all three can attest to.
Absolutely.
So in terms of you were already attending, so what got you interested into infectious disease? Was it the fact you had gotten sick that led to, your kidney disease, or was it something else?
No, it'd been something I'd really been interested in. So when I finished residency, I sort of decided that I wanted to spend some time doing general medicine for a while before I decided to go do a fellowship if I decided to. And I'd spent a lot of time when I was in medical school I spent a bit of time working in Nicaragua during summers and got really interested in seeing the different infections when I was working in Central America. And I'd always found that when I was on clinical service, that the infections were sort of the most interesting to me. And I think after teaching for a few years as a general medicine attending, as a sort of a hospitalist, I found that there was really nothing that I was the expert in. and I decided that it was time to go back. And so it was a little hard because, I was an assistant professor at the time and getting close to becoming an associate professor actually when I went back to fellowship and started from ground zero again. But it felt like it was the right decision. I did a small research project on West Nile virus when I was as an attending, and that really sort of caught the research bug for me and really made me decide I wanted to pursue going into infectious disease. I will say, I thought about it a lot because of, the fact that I'd had a kidney transplant and what that meant. But it really felt like the right decision and the right field. And so I was pretty excited to join it. And then I came here to Washington to do my fellowship.
That's awesome. I love infectious diseases. And I think if I didn't have such a connection personally with cardiology, it's definitely where I would have ended up after medical training.
Mm-hmm.
I personally don't love infectious diseases, Colby.
I love the specialty, not the diseases. Let me clarify. I've dealt with a number of infectious diseases, and I can say for sure that I hate them. Shout out CMV and C.
Yeah, I think part of it is, I think there's this sense from transplant patients and transplant, people who are engaged in transplant. The field that I work on primarily is transplant infectious disease, but I don't focus on solid organ transplant. I focus on cancer patients and bone marrow transplant patients more. But I think part of what I find interesting is as a person who is immunosuppressed working in the infectious disease field, I've heard from a lot of people that, aren't you nervous or scared or, worried that you're going to get something from patients and that potential interaction? My comment is always the same. I just assume that everyone I'm meeting has an infection. And so I'm even more doubly prepared because I know that I'm being consulted for somebody who has a fever. I know that I'm going in to see someone who has a cough, who might have tuberculosis. So I think in some ways, everyone I'm seeing is a potential risk if you want to put it that way. So I don't necessarily worry as much on a day-to-day basis because my assumption is that everyone I'm seeing is infectious. I would say someone like Alin, sometimes I think about the ER being really hard because you don't know who has specific conditions when they walk in the door. In my situation, I know I'm dealing with that in most situations. So it's just a different experience. And I think every physician and everyone who works in the field of medicine has the potential to come into contact with somebody. And it's just a matter of being cautious all the time when you're in an immunosuppressed condition.
Yeah, I agree with you on the ER. For the ER, I tell people that you don't know what people have, which is kind of how you should be in life in general when you're immunocompromised. But then when people ask me, they're like, how are you doing critical care? And I said, well, it's kind of better than being in the ER because in critical care, at least you know what your patients have for the most part. And even if you don't, you're still very protected. So even when I was working in the ER, I did the same thing.
Yeah, and I think that's very similar. I think, and a lot of the infections our patients get aren't necessarily contagious. So a lot of them are, people we can help. I think what I like about the field is that I can give patients treatment and see them get better, and so that feels very satisfying. So it's just a different mentality in how you approach it. I love the fact that I get to work in a space that is related somehow to the work or my history. I don't like to directly. I didn't go into nephrology because I didn't really want to address, kidney disease and see it on a daily basis necessarily, but being somehow related to the field by working in transplant ID is really interesting. And I think it provides a really different insight to taking care of patients that's incredibly unique. I'm not like Ken, who, has kidney disease and sees and works as a nephrologist. I really enjoy being around that space and seeing people who are immunosuppressed and working with the immunosuppressed community. It's a link that really, I think, helps me stay grounded and helps me give back to a community that has really given me so much along the way.
Did you notice a change at all in how you interacted with patients or how much you relied on your own experiences once you had been transplanted?
I don't think so because I'd always, since I was younger, since I was about 17, I'd always been on some immunosuppressive therapy because when I initially developed kidney disease, I started on immunosuppressive therapy and I was on it for years and years and years prior to my transplant. So I always was the same. Went through med school with the same sort of process, and through residency with the same process. And so I think I've always sort of treated it the same. I think it's just given me a different insight into, sort of being a patient and understanding how uncomfortable that can be. And I think that's a real insight that, many physicians don't have initially when they start, but eventually I think everyone has their own crosses to bear from that perspective, and it changes how you are as a physician. But I was lucky enough in some ways that I had this for a long time. So I think it's helped me throughout my training.
Yeah, that's awesome. And, being sick for me since the age of 12, I too think it's just something that's now been a part of my life that's always affected how I interact with patients. So moving into the hot topic, I don't think you can be an infectious disease doctor and not get asked about COVID. So when COVID, started, you are taking care of immune-compromised transplant patients. You are one yourself. Did it change anything about your day-to-day work, or was it kind of just a adapt and see approach?
I think there's no way that anyone can tell you that it didn't change how they worked, whether you were immunosuppressed or not. I think the difference was in the initial phases, everyone was terrified. I wouldn't say terrified, but everybody was very worried about what this meant and the risks for themselves. I mean, we had people that we worked with very closely that, were uncomfortable and would state as such to see patients that were COVID positive because of their concerns. And I think being immunosuppressed, I sort of trusted the protective equipment that I had, and I knew it was important to take care of patients. And so I did. A lot of the first few months, since I work primarily at the Cancer Center and in a role as the director of infection prevention, I wasn't directly seeing patients because I was developing policies and creating places for people to come get tested, and doing a lot of the administrative policy and work to get the center prepared and be dealing with this. And it was a little weird because, we were the first, right? So Seattle was where it started. And so we didn't have a playbook necessarily that we could work with that others had seen and used. And so it was kind of every day coming up with new policies and writing new guidance. So it was really interesting from that time frame. But, taking care of COVID patients, I think part of it was knowing when they were positive made it a lot, again, similar to the same process. It made it a lot easier for me to trust the protective equipment I had and to work with those patients so that I could give them the best care possible. I don't think any of us really went into those situations feeling 100% comfortable all the time, but it's also part of our job, and we had to do it. So we all did. I would say people like, that my colleagues who worked in the ICU and other places where it was, much more regimented. I think those could be very stressful situations. The ones that I really dealt with were patients on the floor who were immunosuppressed themselves, dealing with COVID more than other groups. So it was challenging. I mean, it was a hard time, I think, for everybody. And I think I would say it's gotten easier as we've moved forward, but I don't think it's completely as though we feel as protected as our colleagues do at this point.
Yeah, and at this point, we're now over a year and a half or so from definitely when it arrived in Seattle. And I forget that you're in Seattle, where it was the first place it really, was all over the news. Are you, just because you have such a unique role in terms of disease prevention and all that, are you feeling optimistic where we are a year and a half later, or still kind of pessimistic?
Yeah, it's really hard to say. I think, if you'd asked me in the wintertime and in June and July last year how I felt very pessimistic because I knew we'd be dealing with another wave. But at this point, it's harder to say. I think, I'd love to see vaccines be more accepted by the general community, because that's the best way that protects our immunosuppressed populations. The more people in the community that get vaccinated, the more our own selves and our own communities that I deal with, at least, are protected from COVID. but there's still a lot that are not getting vaccinated around the country. I mean, Seattle's different. We're over 80% vaccinated within the city, who are of age to be vaccinated, and I think we did see the FDA approve kids vaccines this past week, and so the expectation is after ACIP votes that younger children have access, or school-age children, and that may further help to limit COVID exposures. But COVID's been a challenge for many reasons, and one of those is it's not been predictable. In some ways, it makes sense within the infectious disease space. I don't think any of us were surprised that there were unique variants in the different parts of the world where they developed, but I think we just don't know what's going to happen over the next few months. And I think it's when people ask me to sort of pull up my crystal ball and say what I think is going to happen, I really don't know. I think the winter's going to be more cases, but it may not be as much as the prior winter. But I think every time I've tried to predict and think things are right, I've been pretty close to being on target. But this is the first time that I'm not really sure. I really don't know what the next year is gonna mean. But I am somewhat optimistic that by the time we get to 2022, that things are going to get to a more stable process. That we hopefully will still be having cases. There'll still be risk. Every year we're still going to have cases for a while, but we'll start to see a decline in this over time. But it's really hard to predict what the future looks like, because this has been a really, really challenging disease.
Speaking of vaccines, have you heard anything about the fourth booster shot for immunocompromised patients?
Yeah.
What do you think of that?
Yeah, it was just the CDC just posted it on Thursday, I believe. I'm not really sure. I honestly don't know the data to support that fourth dose. I've been looking for it, so that they must have data that they've been collecting, or groups that they've reviewed that potentially talk about this. But I think a colleague who works with me described this really well, and I think this is probably the way for people to think about it, and for transplant communities to think about it, and immunosuppressed populations, is that in the standard population, 3 doses will certainly become, I think, the routine. And so 2-dose vaccines followed by a 3rd dose 6 months later. So if it's Pfizer, and then 3 weeks later a 2nd dose, and then the follow-up would be 6 months later. If it's Moderna, you'd get a dose, and then 28 days later a 2nd dose, and then 6 months after that 2nd dose you'd get your boost. What it will be for immunosuppressed patients is, instead of saying the initial series is going to be 2, it feels like the initial series will be 3. So it'll be 2 doses followed by a 3rd dose 28 days later, and then an additional 4th dose 6 months later. So if you think about it in the sense that a general person is going to get 2 and then that 3rd dose later, then the immunosuppressed population is going to get 3 followed by a boost. So I think that makes it easiest. It just sort of makes the process easier to think through. But the larger question that I don't know the answer to is, where's the data to support that? I haven't seen it, and I review a lot of the vaccine data, but I just don't know. So I'll be curious to see what more information comes out in that space. But I think that sort of, if you think about it in the sense that it's just a different vaccine approach, then it makes more sense. So, a lot of solid organ transplant recipients, as an example, receive high-dose flu vaccine because there's data that it works better in that population. So it may be that you're just offering a different vaccination strategy for the immunosuppressed population because it's felt like they don't respond as well to a standard dose. And then in addition, instead of that, that 2-dose, you have a 3-dose regimen, then the rest of it would be the same. So it'd be more consistent across. And I think that's important because something like Moderna, where you're getting in the initial series, you get 2 doses of 100 micrograms, which is the original vaccine, followed by a 3rd dose of 100 micrograms. And then your booster is half that dose. So for the general public, you get 2 of the higher dose, 100 milligrams, followed by that boost. It just clarifies what that third boost is for immunosuppressed patients as well. And I think that's important because there's been a lot of confusion about boosters, third shots, et cetera. But I think this maybe over time will help clarify that for people who are addressing this who haven't been vaccinated yet.
Yeah, this is all such good information. And I think our listeners, whether they're in medicine or just general public or immunocompromised, are really going to appreciate you breaking it down like this. This next question, given your knowledge currently on the vaccines, if people were wondering about vaccinating their young kids, age 5 to 11, would you recommend they go ahead and get vaccinated?
Well, first, it's not been fully approved yet. The FDA has voted. And,
True.
The FDA has approved. ACIP will vote next week. So in this coming week, the key will be what groups are they promoting, or what do they suggest as the groups who should be vaccinated in that 5 to 11 group. I think, from my perspective, I think kids are at risk for developing severe complications. So it is not as common. And so children in that situation are much less risk than the general, if it was a 70-year-old or a 60-year-old adult, as an example, for developing complications. But there are children that have developed severe complications and died. And some of those children have not had otherwise health conditions that would suggest they would be at high risk. So I think in certain situations, I think this at the moment, since there isn't, more data around this, I think you need the opportunity for families who decide that they want to make this decision to protect their children to do it. And so I think it's a little early for mandates, in the sense that if you're in a situation where children are forced to get vaccinated to go back to school, I think that data may come as it's being used more and more, and there's more safety data. I think that there is a potential that will be a decision that municipalities and states make. But at least in the short term, I think having the freedom to make the choice to do this is important. And right now, if you think about this, a 35-year-old who goes through a kidney transplant is fully able to get vaccinated post-kidney transplant, but a 6-year-old who isn't. And so being able to offer the most immunosuppressed populations, including kids, the ability to get vaccinated is really important. And additionally, within that, if you have a household member, the child who is high risk, and they have younger children in that household, it's wonderful to know that you can vaccinate everyone in that household and protect them. I think the vaccine looks very safe according to the data we've seen. I'm not really worried about side effects, but I think, it'll be great to have more data. The studies that were used by Pfizer to approve to move forward were, about, some are a little bit over 2,000 pediatric patients. And so I think additional data will be great. But I think, it's really a personal decision at this point in time for families to do that. But I love the idea that anyone who does want to get vaccinated can. And I certainly am encouraging friends and family to get it once it becomes available, and if it becomes available for their family members.
Great.
I will point out also that I will point out really quickly that most of the pediatricians that I know are just ecstatic that this is available, because they have been very frustrated that children have not had access to this. And so bridging that gap around access is going to be important. So I wish we'd done these studies earlier in the process, because it would be great to have this, but this is typically what happens with pediatric vaccines is if it's not a pediatric specific vaccine, they're often studied later. But I think it's going to be really important. And I think it's going to be an important piece to getting the pandemic under control, is to be able to get as many people vaccinated as possible. And that includes children.
Yeah, no, again, I think you're giving us such good information that anyone listening can appreciate just your take on the vaccines and the immunocompromised population. But enough COVID for right now. People hear enough about it, and we'll get to it again at the end when we just answer a listener question. But it is Halloween that we're recording right now. And although this will come out a day or two after, just a fun question for you. What is the scariest part about being a doctor?
I think the scariest part about being a doctor is making a mistake. I think if you are a physician that thinks you're always right, they're the scariest people to work with, I think. I prefer to be someone who is always worried I'm going to make a mistake, because I think what that does is it makes me more cautious, and to spend the time looking up information or asking additional questions or checking labs in the middle of the night. When I have trouble sleeping about a patient that I'm taking care of, or if it's keeping me up at night, those are the reasons that, I'm just nervous I'm going to make a mistake that'll hurt somebody, or that I'll miss a diagnosis that will lead to a complication. So I think as much as possible, I sort of see it as a plus minus, in the sense that it gives me nightmares when I think I might have done something wrong, or I think I've made a wrong decision, or I have to make a decision that I don't know if it's right or wrong. Those are the ones that sort of keep me up at night, like a really bad nightmare would, I guess. But I think it also can be a really good place to make sure that I'm making decisions that are the best for the people that I'm taking care of.
The stuff only a doctor's nightmares could be made of.
Making a
But you guys know exactly what I'm talking about.
I do.
I'm sure
completely.
that's true for both of you.
Yeah, waking
too.
up at like 3 a.m. and remembering something, and like texting whoever's at the hospital to double check always happens.
And them yelling at you, like, why are you up looking at this? We got it covered, but we can't help it.
No, I was going to say, all of us have been in that situation where we've been, in the middle of the night, you sort of realize something that you've forgotten, or you realize what the diagnosis is, and you call and quickly change, or, you just have that sixth sense that something isn't right, and you check the labs and you say, oh, I should do something else, and you call the team. Yeah, you can't help yourself. And I think that's the sign of being a good physician.
So to counter that, what is your favorite part of being a doctor?
I think what I really like is mentoring others. I really enjoy working in an academic environment where I get to train and help others become physicians and become researchers and work in the space where I am. I think that's the thing that brings me the most joy, is seeing people be successful, getting a paper published or getting a grant accepted, seeing them go on to become academicians, or people that work in the community as physicians. It's just really exciting to have somebody who you've worked with who's a college student who goes on to be to become a resident or a medical student, and seeing their success. I think that's the most joy I get about what I do every day.
That's a nice answer. I really like that. I always tell people that one of the best parts about being a doctor is how much you have to incorporate learning into your practice, whether you like it or not. We are mentors to not just the next generation of physicians, but also, to our own patients too sometimes. So it's a big role to play. It's a good part too. Yeah.
And I would say, as much as, I learned from, all of the people who've taught me, I learn a ton from the students I work with, and I always learn from patients. I mean, some of my best studies and research that I've done have come directly from patient care, where I've seen someone and thought, gosh, that doesn't feel right, or I'd like to do that differently, or how can I prevent that? That's led to changes in practice. So I think patients teach us a lot that that seems really, cliche, but it's very true. And I think important that the experience in academics and even in just medicine in general is never the same any days. You're always learning.
Agreed. I have a fun question. What is your favorite broad spectrum antibiotic choice? Would you rather be vancomycin or vancomycin?
I would choose vancomycin between the two, but my favorite broad spectrum would probably be, if I have to choose somebody who's really sick. In our immunosuppressed population, almost always we would choose meropenem as a primary source, because we have a lot more drug resistance in our chronically infected patients, or our patients who've seen lots of antibiotics. But I would prefer vancomycin. I think vancomycin piptazo tends to have a little more kidney toxicity, and that always makes me a little bit nervous as a kidney transplant recipient. So I'm always a little more cautious about that.
I think that's every ID doctor's nightmare, is vancomycin.
It's probably true.
All right, Steve, if you're willing to stay on, we'd like you to be a part of a listener question from, this one came from our Ask Me Anything on Instagram. This one is from Andrea. She says, as a solid organ transplant recipient, she's been worried more than ever about getting COVID. She's been vaxxed 3 times with Moderna, but who knows if that'll help much. She's asking, what are we doing to stay safe? And what is this all she hears about monoclonal antibodies?
Yeah, well, Andrea, thanks for that question. I think a really important one is, what can we do to stay safe? So I sort of think about what I tell my patients and what I do. I live in a cautious world. I'm pragmatic about the best way to protect myself. And so at the moment, I still am masking in really public places. So like when I'm walking on the street and I'm walking my dog outside where the air's fresh when it's not raining in Seattle, I'll do so without a mask. But when I am going to a grocery store or I am going to a public space, I'm wearing a mask. And I prefer, if I can, to wear a better mask like a KN95 or a double layered mask like a surgical mask on top of a cloth mask, as an example, or a cloth mask on top of a surgical mask, even better. And that way, at least I know that I'm doing something to protect myself a little bit more if there is somebody in that space who either isn't masked or doesn't wear a great fitting mask. And it always ends up being a good thing because there's always somebody who's got their mask around their chin, talking on their phone, or even right now, there's a lot of young kids that are around and going to school who might be with that parent. And it's just another way to protect myself. I really have avoided a lot of places where there's lots of crowding, so I haven't really been to too many restaurants and things like that to date unless I can eat outside. So I continue to remain cautious about those things. I use a lot of hand gel when I come in and out of the house. I have it with me all the time, as a good ID physician does. But I think, the vaccines are good. And so I've made sure that everyone around me is well vaccinated and has received every dose that is prescribed at the moment. So all those around me have been vaccinated, including all the healthcare workers in my institution have been vaccinated, and all of the people who work at our cancer center have been vaccinated. So I know that I'm working in an environment that's very safe. That helps to prevent potential transmission. And then I have, sort of in my back pocket, this idea that let's say I do develop COVID, because it is possible. Our ability to respond to vaccines is less than the general public. And it's possible that even with 3 doses, potentially a 4th in my future, that I may not have responded as well to the vaccine as my colleagues have. And if I haven't, and I do get COVID, I know that the vaccine is going to help prevent me from going on to developing severe complications. But if it does happen, I still, if possible, and it was available, would try to get a monoclonal antibody. And the monoclonal antibodies are really valuable because they provide an extra layer of protection. And there's data in high-risk populations as well, that generally high-risk patients, people who are more at risk for going on to develop complications from COVID, that the monoclonal antibodies can provide additional protection from the need to go to the hospital or to die from COVID. And the way they're used is early in the symptoms. Once you get diagnosed, you want to reach out and identify a place where you could get a monoclonal. And they're given 2 ways. One can be given IV. The other can be given as a subcutaneous infusion, just right under the skin. They're really easy to do in most situations. It usually takes less than an hour to get a dose. And the advantage is it's sort of like filling your body with lots of antibodies to protect and cover that virus. And so what these antibodies do is they attach to that spike protein, which is what the vaccine is really targeting. And by covering them with these created antibodies, they don't allow the virus to attach to cells and then replicate itself, because they cover all of that spike protein, which is necessary for it to enter a cell. And so that sort of steric influence where it can't actually attach to a cell helps to prevent the virus from replicating. And that's really important in terms of disease manifestations. So if you can prevent the virus from replicating and you can mimic what the antibodies do in somebody who has a good immune response, then it can prevent you from getting sicker. So I think that's what I'd do if I knew I was positive, and what I would do is I would reach out to the local institutions I know well, and I would get a dose of the monoclonal antibody to provide me additional protection. If I did become positive, I'd be very disappointed because I really don't want to get COVID. But I think it's also entirely possible that many of us will at some point in time. The key is if you're going to get infected, make sure that you're fully vaccinated before that happens. And I would not in any way recommend it. So whatever you can do to prevent getting infected is super important, and still taking those small steps like masking up and avoiding big crowds, et cetera, can be really helpful in helping a transplant recipient be cautious and to prevent themselves from getting infected.
I think one of the biggest things in medicine is knowing your limitations, and that is exactly why I saved this listener question for when we had you on, because your response in terms of monoclonal antibodies, would blow much better than what me and Alin would have probably given. But
Thank you so much.
Well, I think it's important. But I do think it's important that, if you are an immunosuppressed patient and you develop COVID, make sure you call and see if it's available for you locally. And there are websites you can go to. Health and Human Services, if you look up Health and Human Services and monoclonal, can tell you of places that are local in your area that might have monoclonals available, even if you aren't in a big city. And for those of you who do live in big cities and can talk to your transplant teams, talk to them in advance and find out where you would need to go or how it would be possible to get a monoclonal if you needed one. It's just a good thing to have in your back pocket in advance.
Agreed. And, just to echo what Steve was saying, I follow the same type of lifestyle as him. If I'm outside walking, I don't really wear a mask, but I still am wearing a mask in grocery stores and things like that, even when, it's not mandated at this point where I live in Connecticut. And, everyone around me as well is also fully vaccinated. So, Steve, before we let you go, is there anything you wanted to give a shout out to or promote while we have you here?
I think I would just take a moment to thank you guys both for doing this. It's great. I would also say that I really want everyone who's listening to this to remember how important Donate Life is, and that all of us who are in the situation on this call today are here because either someone has been willing to donate an organ to us, or have been in a situation where someone who has lost their life has been willing to donate their organs to save someone else. And it's an incredibly valuable gift. And I promise you that each of us on this call today takes a lot of time in thinking about how we can continue to pay that forward. And that there are 3 physicians who work and take care of patients every day because people have been generous in that way. And if you aren't an organ donor, please consider it. Think about how important it is. You can save a life, multiple lives, and it's a wonderful opportunity to give back. And I think we're also grateful to those who've donated to us.
We're very grateful. Remember, you can always register at registerme.org if you're in America.
Definitely. That's an amazing shout out and plug to have to end the show. And thank you so much, Steve, for coming on with us today. I think you gave such valuable information that hopefully, anyone who listens is going to be grateful for your answers.
Thank you, Steve.
Okay. Yeah. And thanks so much for having me, guys.
Thank you again to Dr. Steve Pergam for joining us today. Again, I thought he was such an excellent guest. He gave such good information, not only for the listeners, but for myself as well. And thank you again to everyone who listened. We'll be back again soon with another episode, so please stick with us.
Yeah, you can follow us on Instagram at Both Sides of the Stethoscope or Twitter at Both Sides of the Stethoscope. Feel free to email us too. That's bothsidesofthestethoscope@gmail.com. And you can message us on any of those platforms if you have any questions or if you have any thoughts about who we should bring on to the show. So we'll see you guys next week.
Definitely. And keep the questions coming. We love answering them at the end of each episode. Take care.